Hello, I'm Seth Drobick from the Hospital for Special Surgery, and today we're going to be demonstrating a posterior lateral Mako total hip replacement. Before we get started, I'd like to orient you to the operating room. We currently have a patient positioned in the lateral decubitus position with the right hip up. The head of the bed is in this direction. There are a few pieces of equipment that I'd like to introduce. I'm going to start with the camera. So the camera is at the head of the bed, slightly off the corner, allowing the anesthesiologist access to the patient, and we still have excellent visualization of the screen. Then we have the Mako robotic arm that comes from the anterior aspect of the patient into the surgical field. And then lastly, we have our Mako product specialist who is not in the sterile field but operating our guidance cart. So now we're ready to get started. Let's start by reviewing the preoperative plan. I usually like to start with the screen that is a representation of the patient's x-ray. So this is actually a CT scan, but a simulated x-ray. When you look at this view, you'll see that there are multiple lines drawn. There's a line drawn between the ASIS, between the right and left sides, as well as the most prominent points of lesser trochanter, and that's really how leg length is determined. There's a center line that represents the center of the pelvis to determine offset. And then you have a box at the bottom right of the screen, which essentially shows on the operative side what you are relative to the contralateral side or the non-operative side. So currently we are 3 millimeters shorter than the contralateral side and 1 millimeter decreased in offset. And we'll go through a step-by-step plan to help restore this patient's mechanics. We'll now look at the femoral side of the reconstruction. I often like to start with the femoral side with planning, as that way I get a sense of the native femoral anteversion. The native femoral anteversion is determined off of the epicondylar axis and then the rotation of the femoral neck more proximally. And the center of the femoral head is depicted by this magenta dot. And then we can start to look at how we'd perform a reconstruction in the CAT scan, and you'll see how the femoral stem fits into the geometry of the femoral canal. So currently, this femoral stem is more anteverted than the native femoral anteversion. As you can see, the blue dot is represented by the femoral hip center of rotation. So what I like to do when I'm planning the reconstructions is first size the stem and then also think about the rotation of the stem. So I'll go back and I'll size the stem and then we'll look more closely at the rotation. So I actually like to size the stem on the x-ray view, as sometimes it's difficult for me to scroll through the different cuts to figure out where my contact points are going to be. So I'll often go to the x-ray view, as this is what we're used to looking at, and then kind of move the stem and you'll see how much room there is medially and laterally and where your contact points are. And here I see that I have a couple of millimeters laterally and a couple millimeters medially. So most likely I'd go up to a size 8 stem to try to get some cortical contact along the medial aspect of the stem, and then also a contact point on the lateral aspect of the stem, and that usually gives a good wedge fit or friction fit of the, or press fit of the femoral stem. Right now I'm actually shorter than my contralateral side by 3 millimeters and decrease the offset by 2. So I may elect here to try to go up a head size, potentially to a plus 2.5 head. And now I'm 2 millimeters longer than my original hip, and my offset has not changed. And compared to my contralateral hip, I'm 1 millimeter shorter and my offset is neutral. So going back to the femoral planning on the CAT scan, I would then scroll through the axial cuts to get a sense of where I would use a box osteotome to remove some of the bone posteriorly, and then also look more inferiorly at where my stem will contact the calcar. And I'll get a sense on how much I might be able to antevert or retrovert the stem if needed. And you can rotate your reconstruction to get a better sense of where that stem will lie. You can also look at it on a sagittal view, and here this is a blade taper stem, so typically there isn't any difficulty getting a stem down, but on fit and fill stems and other geometries, sometimes you'll actually be tighter in the anterior to posterior dimension rather than the medial to lateral dimension. So on the right-hand side of the screen, you'll see our current reconstruction. Right now we're planning for a Trident titanium cup and an Accolade 2 stem, and then we can see our cup size, which is a 54, our liner options, as well as our stem size, neck angle, and neck length. Next we'll plan our acetabulum. This is a 3D representation of where the acetabular cup is currently in the pelvis. If you look at the top right, currently is planned at 42 degrees of inclination and 20 degrees of aneurysm. And then it also states what we are doing to the native hip center. So we're 1 millimeter superior and 2 millimeters medial. You can also look at this in 3 dimensions using the CAT scan. So using the CAT scan view, there's transverse, sagittal, and coronal. When I plan on the transverse view, I like to scroll through and make sure that the anterior aspect of the cup is tucked in underneath the anterior wall of the acetabulum. On the sagittal view, I do not like to have any of the cup prominent anteriorly, as that could cause iliopsoas impingement. And coronally, when I scroll through, I like to see that the inferior aspect of the cup is roughly at the level of the teardrop, and that superiorly we're taking adequate bone. In this screen, you see the reaming view. So this is actually the bone that's removed and represents what you'll see during surgery. You can move this in any direction to get a better sense of where you're removing bone. So after the planning is done on the femoral side and on the acetabular side, you can reduce the hip and get a 3D view, but also get an X-ray view. So this represents the X-ray that you'll have in the recovery room after surgery, and it also shows what we did to the operative hip. Now we're 2 millimeters longer, and we did not change the offset, versus the contralateral hip, we're 1 millimeter shorter and did not change the offset. So we've done a posterior lateral approach to the hip. The next step will be placing the pelvic array. So typically I palpate the ASIS, and approximately 3 finger breadths posteriorly is where I center the center pin, and then there are 2 flanking pins. And then you just have to be cognizant that you want that array facing towards the camera. I usually do this from the posterior position, so I'm going to walk around and do this as I would in surgery from the posterior side. So right now I'm going to palpate ASIS and just mark that out as a reference. And then typically it's about 3 finger breadths up from that is where I center the array. I'll take a knife, make 3 stab incisions, and you can feel the inner and outer table of the pelvis. I just center myself right in between. Make 3 stab incisions. Then I'll take a pin, load it up on a pin driver. At a 45-degree angle, drive the pin into the pelvis. I then use my clamp as a guide for the other pins. And screwdriver. And then I tighten my clamp. I make sure that it's sturdy. And then there's an adjustable bracket for the array, pointing the array towards the camera. And on the left-hand side, you can see the field of view of the camera, and the blue dot represents that it's visualized. Tighten up all the connections. Make sure it's sturdy, which it is, and you're ready to proceed. Next, we have to insert a checkpoint into the lateral aspect of the greater trochanter. We've already placed an EKG lead on the inferior pole of the patella, and we have to register both points to establish our preoperative leg length and offset. Using the foot pedal, I'm going to capture the proximal point, and then coming distal with the leg neutral and without moving the leg, capture the distal point. It's very important that we do not move the leg in between points. Now we're going to place the pelvic checkpoint. It's approximately 2 centimeters above the edge of the acetabulum. I'm now going to register the pelvic checkpoint by placing the probe into the point, capturing it once, and then repeating. After taking our points, we are now going to dislocate the hip. From preoperative templating, we planned our neck cut. So next step is registration. The first 3 points are our bony landmarks. We're going to start with our posterior point. And it's important that you get these points where they're depicted, as it sets up the reference frame for the rest of our registration. It's also important to push through soft tissue onto bone so we're accurately registering off of bone. So once the first 3 points are done, then we go to the fine registration, which are several points within the acetabulum, establishing the center of rotation. And again, it's very important that we push through the cartilage onto bone because the CAT scan is referencing bone. I'll try not to block your view, but some of these points I may have to obscure the view slightly. It's also important for camera setup to make sure that the probe is easily pointed towards the camera so all these points are easily collected. So now we're going to go to the rim points. And again, there's oftentimes labrum and sometimes soft tissue along the rim. So you oftentimes have to push through a little bit of soft tissue or labrum in order to accurately obtain points off bone. I try to spread these points out as much as I can. Oftentimes, if there's osteophytes, I'll even move off the osteophyte because the osteophyte can be soft and the tip can plunge. There is a large osteophyte on this specimen anteriorly, so I'm going to be careful to take points as accurately off bone as I can. So when you look at the registration, our overall confidence is 0.3 millimeters, which is good. You can see that there's a spread of some green dots, yellow dots, and red dots. The green dots represent basically points within a 0.5 millimeter of plan, yellow dots between a 0.5 millimeter and 1.5 millimeters. And I had one deep spot here, and you can actually, if you look at the CT scan, there is a little hole in the bone, so I probably fell into that hole. But otherwise, I'm happy with the registration. Next point is to validate our registration. So we go to each one of these spheres, and when it turns translucent and then the tip is on bone, you'll be able to see on the top right corner that I'm within about 0.34 millimeters of bone. And this just validates that our registration is accurate. If you're unable to register these points or validate these points, you may want to consider re-registering. Sometimes it's hard because you have to balance right on the tip of an osteophyte. So I wasn't quite close enough, and it's right on the edge of that osteophyte. So our validation passed. So next step will be going to reaming. So now we're going to bring the Mako robotic arm into the surgical field. As you can see on the right-hand side, we do have some freedom to move the arm and still have power and ream. On the left-hand side of the screen, you can see that we have power as this green checkbox around the reamer. And currently we're looking at our plan. We have to go superior approximately 6 millimeters, medial 6 to 7 millimeters, and posterior 2 to 3 millimeters. So I'm going to line up as close as we can to the plan, but we do have some freedom. We're just trying to ream to the center of rotation, and then I'm going to start to ream. We start to remove bone, and you'll see that the distances that we have to travel are less. And then as I get close to the final point, I slow down. And we've removed all of the green and just a little bit of red, but we've essentially hit our center of rotation, as you can see by all the green superior, medial, and posterior distances. All right, I'd like to highlight that we planned for a 54 millimeter cup. We single reamed with a 54 millimeter reamer, got an excellent bleeding bone surface and concentric surface ready for impaction of the acetabular cup. I now have the acetabular cup loaded onto the inline offset impactor. I bring the acetabular cup into the acetabulum and then bring the robotic arm onto the impactor handle, sliding it down to the laser line, and then attaching the impactor pedestal. I roughly position it close to our plan and then have my MPS lock in the plan. Now the robotic arm is rigidly held, and it even changes with the orientation of the patient, holding our plan in place. And then I have to slide the arm down and capture. I want to see how many millimeters I have to progress. I have to impact this cup 10 millimeters. So what I'll do now is I'll impact onto the impaction pedestal, driving the cup into the pelvis 10 millimeters. So now I'm going to impact the cup approximately a centimeter, capture. So we still have 5 millimeters to go. Capture, 1 millimeter. Capture. One more time. Capture. And we're about a millimeter up. I'm going to remove the arm. Now I'm going to double check to make sure that my cup is down. And it looks as though it is on the center hole. So I'm happy with that cup position. So the next step is to manually prepare the femoral stem. I do have a sense of my anteversion, so I do plan, and the pre-surgical plans we did, roughly where my box cut will be in order to set my anteversion. There it goes. Yep, now we start broaching. Here. I've completed broaching and now we're going to trial. I'm going to reduce the hip. Let's take out the retractors. Okay, and we're going to bring the hip down and in. There we go. I like the feel of the soft tissue tension. Capture. And without moving the leg, take the second point. All right, so now we're currently 1 millimeter long and increase the offset 1 millimeter versus the contralateral side, we're a millimeter shorter and have increased by a millimeter. Personally, I think this is acceptable, so I would take this in surgery.